Welcome everyone to the weekly webinar presentation of the Institute for Public Health and Medicine here at Feinberg's Northwestern University's Feinberg School of Medicine. I'll take just a moment to briefly mention, as we always do, that we don't monitor the chat during our presentations. We do welcome questions of our invited speakers and would ask you to use the chat function. The Q&A function at the bottom of your Zoom screen to enter any questions at any time during the presentation. Do not use the chat. We won't be monitoring it. As questions come in, we'll collect them, and then time permitting at the end of the presentation, we'll invite our presenter to answer those questions. So please do feel free to ask any questions in the Q&A area. Our presenter today, we're fortunate to have with us Maryann Mason, who is Associate Professor of Emergency Medicine here at Feinberg School of Medicine. And Maryann is a sociologist whose research seeks to understand environmental, cultural, institutional, and social influences on health and well-being across the life course, especially in minoritized communities. She leads violence and injury research in our Buehler Center for Health Policy and Economics here in IFAM. And her talk today is titled Preventing Older Adult Overdose Using Data to Identify Touch Points. The talk will serve to demonstrate an application of advanced analytical techniques to public health data on overdose death, as a means to identify touch points for outreach and service delivery, including screening, harm reduction, and treatment, with the goal of improving older adult opioid overdose prevention. So without further delay, please join me in welcoming our presenter, Dr. Maryann Mason.
Thanks, Ron. I appreciate it. Appreciate the introduction. Good afternoon, everyone. As Ron said, I'm going to be talking about the older adult overdose problem and how we might use data from decedents to improve our outreach. So I bet one of the things you weren't expecting today was to see an elephant on the screen. And the reason I put that there is there's a social worker term called the graying elephant in the room, which refers to the growing problem of substance misuse among older adults. And so I wanted to kind of contextualize this issue and this problem as something that's fairly widespread and of concern in terms of public health. So just to wipe the slate clean, I have no interest to disclose or any conflicts of interest. I have a simple goal for today, which is to provide some education and updates on older adult overdose, and then take you with me on an exploration of some database methods for identifying opportunities to prevent and intervene. And we call these opportunities touch points. So touch points are really encounters. They're exchanges between people, between institutions, and what they do is they give us opportunities to identify and intervene with individuals who are at high risk of opioid overdose and opioid overdose death, so that we can deliver evidence-based services and education and screening and connect to treatment and all the things you need to do when substance misuse is present. So I want to credit Rochelle, who wrote an article on using touch points in overdose prevention, because it's really influenced how I think about the work we need to do in this area. So let me give you some context here. These are unintentional drug overdose death rates for the U.S. for a 22-year period, and I compare the younger versus older. So just so you know, when I'm talking about older, I'm talking about ages 55 plus. and there's a reason for that. But 55 plus is our older adult group. So what you can see is the rates are going up and up and up, and there really isn't much of an end in sight here. What you'll see is the younger adults, that the 15 to 54-year-olds, are at a higher level. Their overdose death rates are higher, but that older adults are following that pattern pretty closely with the up and up and up trajectory. And then if you just zero in on the older adults, you can see that the death rate has increased significantly from 1999, which is the base year most of our studies use, to 2022, which is the most recent data available. The increase is over 1,000%, the rate increase. So it is a troubling trend, right? And then, you know, I started out talking about opioid overdose, but really we're in a polypharmacy or a polysubstance era now. And this graph really shows you that. Here I graph the overdose death rate from 1999 to 2022 by substance type. And so the bright green line is other synthetics. It's mostly other synthetic opioids. It's mostly fentanyl. But you'll look at the dark green line is neck and neck and intertwined. And those are stimulants. So those are things like cocaine, meth, those types of things. So you see, it's no longer an older adult opioid problem alone. We've added to the mix with substances. So it's a growing problem, but it's also an evolving problem in terms of what substances are involved. In Illinois, whose data I use in this project I'm going to tell you about, the percent of older adults, the percent of overdose deaths for older adults, no, let me rephrase that. The percent of all overdose deaths is increasing among older adults. So over the years, and I just plot 4 years here, you see that the proportion of those age 65 and plus is increased, with a pretty big increase in 2022 for the older adults, both 55 to 64 and 65 plus. So locally, contextually, it's a problem for us as well. So why does this surprise some people? I often talk to media and others about opioid overdose among older adults and overdose in general among older adults, and they're surprised by it. But the thing that keeps us surprised is ageism. We just don't think of older adults as people who use substances. But culturally, this generation is different from the ones that have gone before it, in that they continue to use substances into their older ages. And I put up a couple of people here who are famous for their substance use into older ages. So we have to adjust our thinking to the cultural landscape that is America today. By the way, I just saw that Willie Nelson turned 91 last week. So it's an amazing landscape of older adults. So why focus on older adults? Well, number one is they're overlooked as we consider the opioid crisis and the overdose crisis. So they don't get a lot of attention and a lot of resources. But also, older adults are kind of walking a tightrope. They're more vulnerable to substance use than other age groups. And a lot of that has to do with the process of aging. We metabolize substances differently as we age. There's more exposure to substances as we age in terms of polypharmacy, and also the idea of over-the-counter drug interaction with substance use is more predominant with the older adults. but also the consequences of overdose can be more severe for the older adult. If someone overdoses and falls, breaking a hip or breaking a limb is more severe for an older adult because they have the complications of aging. So they suffer more severe consequences when overdoses occur. Another example of that is strokes that accompany overdoses. Older adults are more vulnerable to that. And finally, when we look at sort of the other side, when people are staying away from or going off substance use, they can have their withdrawal and their recovery complicated by comorbidities, and they can suffer more severe consequences. So there's a lot of reasons why we should be concerned about the older adults who may be misusing substances. So I want to switch gears a little bit here and just give you a lay of the land about how overdose prevention looks in 2024, because it sure looks different than it did in 2010, 2018, even 2021. So we have a lot of different levels which overdose prevention is active. There's preventing drug initiation at all. And for example, that's things like looking at alternatives to pain management that don't include opioids, like physical therapy and other non-addictive substances. There's a push to monitor and limit prescriptions, especially of opioids, but I think we can extend that to stimulants in some ways. So the CDC has issued opioid prescribing guidelines that cut the number of opioids that can be prescribed. There's a prescription drug monitoring program, which requires logging of opioid prescriptions, and that's to prevent doctor shopping and multiple prescriptions. It's also to identify doctors who may be overprescribing. And then there's just the polypharmacy awareness. You know, are we co-prescribing opioids and benzos, for example? We're much more aware of how dangerous that could be now than we had been in the past. One of the big advances in substance misuse treatment is the availability of medication-assisted treatment for people who are dependent on mostly opioids, although there's some availability for alcohol too. So sometimes this can be offered on its own. Sometimes it can be offered with cognitive behavioral therapy. But the primary medicines for that are buprenorphine and methadone, which basically take away the craving for opioids and allow people to cut back their use or stop use altogether. And Suboxone is a combination of naloxone and buprenorphine. And then naltrexone is actually more often used for alcohol dependency. But these are medications that can really help people recover from dependency or reduce their use. Unfortunately, we don't have similar medicines for cocaine or meth. Methamphetamine. So we're at a little disadvantage there, but as I understand it, that is evolving too. And then let's talk about what intervention is going on right now. We have screening, universal screening for substance use or misuse is recommended. Everyone, every time. We know that's not the reality, but it is a best practice. And then harm reduction. And harm reduction is a philosophy and a practice that has really evolved over the last 10 years. And it can include a wide range of things. It can include naloxone distribution. And just a reminder, naloxone is a drug that can counter an opioid overdose. And so it can reverse an opioid overdose and potentially save lives, and it saved many, many lives. The distribution of test strips so that people understand what is in their drug supply. And at this point in time, there are test strips available for fentanyl, xylazine, benzodiazepine, and this continues to evolve. And just if you've not heard of it, xylazine is a non-opioid animal tranquilizer that has emerged in the drug mix. And it has a very heavy sedative effect, but it also is associated with the development of skin wounds. And so it's much concern. But we also have other things. We have community drug testing sites where people who use drugs can come in and bring a sample of a drug they've used or are going to use and get a actual chemical analysis of what's in it. And that can help inform how and when they use. There are hotlines. Massachusetts has done a great job with building a network of hotlines. It's called Never Use Alone. So if there's somebody who's opioid dependent and is considering using, but they're alone, they can call this number and someone will stay on the phone with them to make sure they're not overdosing. And if they do become non-responsive, EMS gets called to their residence. There are safe consumption sites. We don't have any in Illinois, but New York City has them and Vancouver has them. They have been proven to reduce overdose deaths and are an effective harm reduction strategy. There's safer use guidance, which tell people how they can use drugs more safely, whether it's smoking or snorting instead of injection, or taking a test shot, or not using alone, or any number of behavioral things they can do. There's syringe exchanges, which are very helpful in reducing transmission and Hep C transmission, and also in connecting people to health and other services they need. And then a new one for me that is on the scene now is called the Sobering Center. And I believe this has been used mostly in the meth arena, where people who are experiencing an overload of a substance can come in and have some time to come down and sort of even out. So I think that's an interesting development. That's a newer one. So let's talk now about the older adult who uses drugs and their engagement in overdose prevention. One way to summarize that is older adults are overlooked and underserved. We know that they're screened far less often than younger groups, younger adults. We know they're less often offered Medicaid or medication-assisted treatment, which is a shame because it is effective with that group. We know they're less often reached with harm reduction services for a variety of reasons, but we know that harm reduction services as they're delivered now do not reach older adults at the rate they need to. Also, this is a population that has some additional barriers to treatment participation. They may have effects of aging that affect their mobility, their hearing, their eyesight, which doesn't allow them to participate fully. They may have transportation barriers, and they may have some complex medical conditions that need to be managed. So they may not be eligible for treatment in a non-specialized center. But we also know that stigma is an especially big barrier for the older adults. A part of it is a historic problem where the use of needles was stigmatized. There's a real aversion to it now. It had a lot to do with the rise of the HIV epidemic. So people equate that with a negative thing. Many have used substances earlier in their lives, stopped for a period of time, and now have begun again. So they're really kind of under the radar with that. They don't want their family and friends and community to know they're using again. So they're less likely to come out when harm reduction services are offered in a, a mobile van or something like that, because they don't want to be outed, if you will. And then there's just a lot of negative, and again, I think this has to do with the point in time which people started using substances, that there's just a lot of negative language around people being junkies or addicts, which we don't use anymore, but people carry that with them. And so it becomes part of their reality in today's climate. So we know it's problematic to reach these groups of people. And we know that interventions that are specifically designed for older people are not very common. In my work in this, I've actually only found one kind of well-developed, evaluated intervention. It's set in Florida. It's called BRIGHT, the BRIGHT program, and it's for older adults. But other than that, there's not much out there. So in a survey of a review of older adult treatment and what's needed, Hafford and Letchfield have made recommendations that are still valid today, that we need to develop sustainable and well-designed intervention strategies for people later in life, because the reality is they are using and dependent on substances. But two key characters of this have to be that they have to be aligned with other areas of things going on in those person's lives, and particularly health and well-being. It has to be integrated and aligned with how people see and deal with their health. And the delivery has to be in locations where older people are normally going, or they're seeking or receiving help. The idea of track is less attractive, less successful with the older adults. So we have to think about reaching people where they are, reaching the older adults where they are. So we thought a lot about this, and our study team is myself. We had a medical student who interned with us, Kavit Pendia, and Alexander Lundberg, who is an economist in the Buehler Center. We thought long and hard about this, and we thought, we have access to surveillance data on drug overdoses. Can we apply some advanced statistical methods to think about what the prevention opportunities may be? So we launched a project. It eventually was published in the Harm Reduction Journal, and the information on that is on your screen, so if you want to look that up, but I'll be talking about that right now. So our goal was to respond to the need, right? To what issues are going on for older adults who've died by overdose. So we want to use the information of people whose lives have been lost to inform efforts to avoid loss in the future, right? And we want to be able to see, can we find touch points? Are there places or situations where older adults who use substances might be reached, again, informed by decedents? And can we identify potential intervention components from these data? Turns out this is kind of a tall order, but we have made some progress in this. So the first thing you should know is that we're using the Illinois State Unintentional Drug Overdose Reporting System, which I'm the PI of, and operate as a bona fide agent of IDPH. So IDPH is really our partner in all of this work. So this is part of a national system, SUDOR. It's operated through the CDC and through its Overdose to Action initiative. And so SUDORS is the mortality surveillance aspect of that. So what it does is it creates the most comprehensive data set available on drug overdose death, unintentional drug overdose death. So we pile together, and we have a team of data abstractors on our team without whom any of this work would be possible. So thank you to those hardworking individuals. So the data abstractors are collecting data from death certificates, coroner medical examiner reports, autopsy, and toxicology reports, and they're entering it into an online system created by CDC. This has over 1,000 variables, and it's been in operation from 2018 and is currently ongoing. So in Illinois, we SUDOR currently covers 84% of unintentional overdose deaths in Illinois, and about 76% of our 102 counties are participating. So it's not perfect coverage, but we are reaching the majority. And we grow this every year. We're adding more counties. And again, we couldn't do it without them either. So thank you to our counties. So I'm going to go back a little bit here to describe this data because I think it's important. So the data include the demographics of decedents. They include the circumstances that led up to the fatal overdose, details about the fatal overdose, all of the toxicology involved. It's quite extensive. And these details come mostly from the coroner medical examiner reports, and that information is gathered from first responders, death scene investigations, interviews with family and friends. So it really is an in-depth look at how these people died and what led up to it. So we include cases from SUDORs in this study that happened between January 2019 and December 2021. Their manner of death is all unintentional drug overdose. They are all 55 years of age or older, and all the cases are recorded in SUDORs. So we have some methods that we use, kind of 3 buckets of methods. First of all, we use qualitative methods in a limited way, but what we try to do is create some categorical latent variables from the narrative. The data set includes a story or a narrative of each death, what happened before, what the history of the person was, what the drugs involved were, all of that. So it's a little story about the death. And we used a bag of words methodology to identify a couple of latent variables in those data that weren't available in the structured data, and I'll explain that a little later. We, of course, did descriptive analyses so we could learn more about the decedent. And then we applied latent class analysis to identify distinct profiles or classes of older adult unintentional drug overdose decedents. So the classes are groups of decedents that hold together on probabilities of multiple variables. So this is a quite powerful method for us to get beyond one dimensional look at this and look at how things combine to form a category or profile. So here's the bag of words we used to create 2 latent variables for the analysis. One was social isolation. So social isolation will have, if it's present, it will impact our availability to identify touch points, but it also is a risk factor for older adult substance use. So we coded the narrative for all these terms, and if they were endorsed for any of those terms, they were endorsed for social isolation in that variable. And then we did a similar thing with pain. So the decedent's experience with pain. And we listed medical conditions that are known to be associated with pain. Then we're able to create a latent variable called pain. So I just want to give you a little example of how we got to these latent variables. So here's an example, and I apologize if this is a little much for people, but these are the things our data abstractors read all day long, so you can appreciate their work. So we find this is a 62-year-old, a Black non-Hispanic female. And unfortunately, she was discovered decomposed in her home. And there was a well-being check because her Meals on Wheels packages were stacking up outside the apartment. So these things, the discovery of a decomposed body, having to do a well-being check, and then the stacking up on Meals on Wheels packages made this to be coded a social isolation case. So that's how that worked. But you can kind of get a flavor of the info we're dealing with here. And here's an example of how we coded pain. This is a 62-year-old white non-Hispanic female. So she was last known alive 2 days prior, but she was complaining of having pain, labored breathing and pain. And then her daughter hadn't heard from her, so she went to her residence with she found her deceased. And she had a history of some painful medical conditions named here, and so this decedent was endorsed for having a presence of pain. That's how that worked. So now I want to talk about the other variables included in the LCA analysis. So we have alcohol positivity. We know alcohol interacts with substances and can have a negative effect, so we're interested in that. We just use sex as a descriptor. There's isolation, the one we created, but also here's, did they visit the ED within the last year? Were they in treatment for pain at the time of their fatal overdose? Pain, the presence of a painful physical health condition or mental health condition, and then race. The combination of variables in this model were chosen partly so we could have a description of who was in, what kind of decedents were in each profile class, and part of them were chosen because we were interested in touch points and how we could intervene. So here's the descriptive analysis. We can see that these decedents are primarily male, largely in the 55 to 64 age group, and primarily Black. We also see that it's kind of half and half on the experience of pain. Almost half of them had some condition or evidence of pain experience. Only 8% were in treatment for pain. A third tested positive for alcohol. And then only 7% had an emergency department visit in the last year. And about 16% had social isolation. Okay, so the latent class analysis is run, and these are the results we get. This is a radar plot, which I love as a way to display this data. So what you can see is there's 3 classes of decedents that have emerged. The first class has a high probability of experiencing pain, higher probability than the other classes of being white, a lower probability of being male, a mid probability of alcohol presence, and the highest, although low, probability of having an ED visit or isolation. Then our class 2 is kind of in the middle on pain, very low on pain treatment, less likely to be white than class 1, in the middle on male, very low on alcohol, very low on ED and social isolation. And then class 3 is most likely to be male, or high probability of being male, low probability of being white, extremely low probability of being in pain treatment, and lower probability of pain, higher probability of social isolation, low probability of reaching an ED in the year before, and highest probability of alcohol. So you can see these classes are different in the factors we looked at. So here's just another way to look at it, and I've sort of highlighted where the red class stands out, where the blue class stands out, where the green class stands out. And again, when we say high probability, it's relative to the other classes mostly. Okay. So for example, the class 1 has a very high probability of experiencing pain and the highest probability of having pain treatment, the highest probability of visiting an ED, and the highest probability of being white. That's a distinctive class to the other two, and so forth. So here's just a verbal way to explain these classes in terms of their probabilities, but also the frequencies of membership is interesting because you can see among the decedent population of older adults who died from an overdose, you can see nearly half of them are fitting into class 3, which are fairly socially isolated, least likely to have a healthcare encounter or to have pain, and most likely to be positive for alcohol. That's a very distinct class compared to class 1, which is only 13% of the decedents who are more likely to be white and female and have healthcare touch points. Okay. So there are limitations to this work, and here are a few. One is that LCA is limited in the number of variables we can consider in the model, mostly by our human ability to make sense of things and keep things in mind. Generally, I've been told LCA variables should be limited to 7 or below. I think when I do this work again in the future, we'll look at the variables in the model a little differently, maybe change some things up. Of course, the biggest limit, we don't have a comparison group of non-decedents. So it makes it really difficult to isolate risk factors. All we can tell you is where people who, older adults who died of an unintentional drug overdose were in these profiles. And there are time delays. These data go through 2022, but we know this is a fast-moving epidemic and that things change, so that is a consideration. So I'll just finish with a couple of things I'm thinking about, and this needs more work, of course, but if we look at class 1, we see they're the smallest class, but they have maybe a higher chance of being reached through healthcare settings, which is how we generally think about intervening in substance misuse. So these are sort of the people for whom the classic outreach or screening and treatment referrals and all that might have a higher chance of success. Class 2 is a little more difficult. They are socially connected, maybe the least socially isolated. And it doesn't give us, they're not using the healthcare system like class 1. So it doesn't give us a lot of tangibles to identify, but we think there are places where seniors are going that services could be delivered in a non-stigmatized way. And here's some examples: senior centers and just social events, especially among veterans. And then class 3, this is the largest class, and I think possibly the hardest to reach class. I think this is a class that may be best reached through the places they're already going, which, with the high degree of social isolation, things like services for unhoused persons, the high score on alcohol may help us connect substance youth screening and alcohol disorder connections and services. But I think there's also, this is a relatively income limited group in that there are ways to connect to things like social services for seniors. And so thinking about connecting outreach, screening, treatment, harm reduction in those environments will be important for this group. So the next steps, like I said, I want to think about different variables to rerun the LCA model. I am looking at a multi-state study, and I want to just continue to explore the implications for how we do outreach and intervention in these settings. I'm particularly interested in how harm reduction is delivered. And we have an intervention running now in 5 sites where we're going door to door offering harm reduction services in areas with high overdose fatality rates. So I want to think about how we make that more older adult friendly. So I also want to thank you for having me today. And if there are any questions, I'm happy to answer them. Here's my contact information. If you would like more info or to talk more, I'm happy to do that.
Wonderful. Thank you, Maryann. That was really great. And we do have some questions. I want to start. I thought it was really interesting where you finished in terms of thinking upstream to what would be the potential opportunities to intervene and avoid overdose fatalities based on or other adverse outcomes based on the sort of different sort of classifications of patterns of the user. And I think some of the things that you talked about were very like you made the point of intervening where people are already going and thinking about contexts that are specific for older adults, and that seems to make a lot of sense. And a lot of your examples were physical places. I wonder in the world today whether social media has a role here. I realize communication challenges and access issues and things like that to different forms of social media. But do you know even what % of the different groups have phones or are reachable or might be using Facebook or social media platforms? Is there a potential for a virtual touch points that are maybe broader reach, but don't reach? Just as an alternative, I'm just curious whether you've thought about that or whether that's at all a consideration.
I actually have thought about it, but in a little bit different way. Some of my thinking was that the phone and social media use may be limited for this group, and I don't have the data on that, but I was thinking about reaching out to the children through social media, the children of older adults, in terms of education about the older adult substance use dangers, as a way to educate the family members. One of the things I often see in these narratives is that the adult child knows about the parents' misuse, checks on them, and has found them overdose. So I'm just wondering if there might be more education about harm reduction that route. But I think you make a good suggestion for the social media aspect for older adults directly as well.
Great, thank you for that. We have another question from the audience. What kind of an analysis or visualization specifically was used for your latent class analysis? And they refer to slide 25. I don't remember which. It might have been your spider web figure.
Oh, that's called a radar plot. I love these radar plots. I think it is very intuitive in terms of how you can read it if you spend a minute or two with it. There are many, many ways to illustrate latent class analysis results. This one was just my favorite because it was easy for me to understand.
Yeah, great. Yeah, that one done. So we don't have a lot of other questions. I wonder, are there opportunities, Maryann, or what are the opportunities in your mind to involve people if they're interested, folks in the audience that are interested in your work with suitors or on overdose reduction in general? What's the best ways for them to get involved or to engage in the work you're doing?
I think reach out for a conversation. There are many different types of opportunities. I've worked with students over the years in sub-studies and publications that have led me to this work. So there's that. I'm also interested in partnering with people who are on the implementation side of things. I think there's lots of room for that. And also communication. I think if people are interested in public health communications, there could be some really great partnerships there too.
Thank you for that. And reaching out, would they reach out to you directly or to the Bueller Center, or what's the best mechanism not to overwhelm you with?
Yeah. I may regret this, but I'll say reach out in my email. I think that's the best way. We do have a SUDORS, and I should explain this. We do have a SUDORS dashboard for people interested in looking at some of the data. The data are available for the state of Illinois and then for counties. And there's lots of different data points in it if people want to explore with that. All you have to do is Google Northwestern SUDORS, and you can come up with that. That's one way to reach out. And then there's an information contact site through that as well.
I had one more question that I just recalled. I wonder if I may ask is, you know, the work that you shared, the early slides on intervention opportunities sort of encompass broader solutions, and then as you moved into your analysis and the touch points, I think you know, tended to focus on individualized or targeted interventions for particular groups. And I wonder, like, on the policy side, are there particular policies for opioid overdose reduction that you think are particularly suited for older adults? Or are there any that are being discussed or promoted that you think would be not helpful? I'm just curious of your because we hear about a lot of those, you know, in the media, and they're debated politically. So I'm just curious what your thoughts are on policies.
Yeah, I actually do have a couple of my favorites. One is related to Medicare Part D, which, you know, no policy is without unintended consequences. So last summer, the FDA made naloxone, the overdose reversal drug, available over the counter, which is great. I think it will be, depending on the price point, it will make it more accessible. But what that also did was remove coverage of naloxone prescribed with opioids, remove the coverage from Medicaid, so people now have to purchase it on their own. So for older adults on a fixed income, it could become a barrier to having naloxone available. So that's one of the policies. You know, the good part of it is it's available over the counter. The bad part is it actually makes it a little more difficult for the fixed income senior to obtain it. So that's one of them. And then there are some differentials in how non-opioid care can be delivered in terms of Medicaid versus and Medicare versus private insurance. And so removing some of the penalties under Medicaid, which requires the lowest cost option to be used, would be great, because some of the non-opioid pain care alternatives cost a little more, and so therefore aren't available through Medicaid or Medicare. So things like that, I think, are really important. But I also think, and I'm going to be radical here, I also think we have to reevaluate our goal of abstinence for the older adults. You have to consider that many in this population have used substances for 30, 40, 50 years, and the idea of requiring abstinence to get treatment or services or management is unobtainable and unimaginable for them. So are there ways we can help people be safer while they use? And so that's part of the harm reduction program, but I think we need to think about what that might look like for the older adults in a more comprehensive way.
And I think you addressed some of this, but there one of our audience members was asking about Medicare and Medicaid coverage for the interventions. I think primarily you were referring to medication interventions. I don't know if you have anything additional to add about coverage for other services under Medicare and Medicaid, and whether it's supportive of the types of initiatives you think would be helpful for this population.
Yeah, actually, I'm not expert in that, so I don't want to say anything that might be wrong. But in general, my thinking is that more community-based non-medical services need to be covered under those programs, because as we can see, like class 3 isn't going in for medical care, isn't touching those places where Medicaid and Medicare are covered. So we have to think about what are the other environments that could possibly be reimbursed for services.
Yeah. And our last question relates to your point about the one of the classes that was the smallest but most likely to be in healthcare settings, and that being an opportunity for a touch point or intervention. But pointing out your earlier comment that screening is not implemented routinely in health delivery settings, and the question really relates to do you see opportunities to improve that, and is there value in expanding the types or array of different settings where in the healthcare sphere where screening might take place? And this the question comes from a physical therapist, so just thinking more broadly.
I think yes and yes. Yes, I see many opportunities in healthcare settings where screening could be done. There are a couple of tools specifically for the older adults that I think are important, because most of the screening and criteria are for people at different life stages. So people who might be, have a higher chance of being employed or taking care of family members and things like that. So I do think the many different places where people receive health care, it could be, their blood pressure screening events. Let's just add a substance use screening to that event and make it all part of health, not make it come to this place if you have a drug issue, that type of thing. And I do think, OT, PT would be great places for that. There are places where people who have pain go. I also think pain treatment centers would be a really good place to have those conversations. Primary care, lots of places.
Well, with that, we're near the top of the hour. Dr. Maryann Mason, I'd like to thank you for taking time and sharing your work with us today. This is really exciting and taught us a lot more about this issue and ways to engage and think about the challenge, particularly for over adults. And thank you so much. Thank you for presenting today at the IFAM webinar.
Thanks. Nice to be here. Take care.
Bye-bye.